Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine for a moment a core part of your digestive system, your small intestine, is significantly compromised. What happens then? How does your body cope with that profound change? And what extraordinary medical interventions become available to sustain life when this vital organ just can't do its job anymore?
That's precisely what we're diving into today. This deep dive is all about understanding short bowel syndrome and intestinal failure,
Okay.
two conditions that fundamentally impact how the body absorbs essential nutrients. It's really a journey into the remarkable resilience of the human body and, well, the incredible advancements in medical science.
Absolutely. Our mission today is to unpack the precise definitions of these conditions, explore their often surprising causes, understand how the remaining anatomy plays a critical, quite nuanced role in a patient's prognosis, and then dive deep into the cutting-edge medical and surgical treatments that help patients navigate these complex challenges. We've pulled together some really in-depth medical insights to guide us on this fascinating exploration.
Sounds good.
So to really get started, let's clarify the bedrock terms. What, at its core, is short bowel syndrome?
Right. Short bowel syndrome, or SBS, is basically characterized by intractable diarrhea and severely impaired nutrient absorption.
Okay.
It typically happens after a significant portion of the small intestine has been surgically removed or maybe bypassed.
Right.
And the end result, without intervention, is progressive malnutrition because the body just can't absorb enough from what's eaten.
So if SBS describes that immediate functional problem because the anatomical loss, how does intestinal failure fit in? Is it like a stage of SBS or is it something distinct?
That's a great question. Intestinal failure, or atinus, it's a broader and more severe clinical state.
Okay.
It's defined by the body's inability to maintain satisfactory fluid, electrolyte, or nutritional balance without needing these vital components delivered directly into the bloodstream.
Intravenously.
Intravenously, exactly. So while SBS is about the underlying anatomical and functional deficit, IF is the severe consequence of that deficit, requiring external, often lifelong, support. The critical point here is that the mainstay of treatment for IF really is parenteral nutrition. We'll definitely talk more about that later.
For you, the listener, this really highlights just how critical the small intestine is for our daily functioning. It's something most of us probably never give a second thought to.
That's true.
Until something goes wrong.
Yeah.
Okay, let's unpack this. What leads someone to develop short bowel syndrome? What are the most common culprits, that put a patient in this challenging situation?
Well, the most common causes are usually surgical resections, which are needed because of various severe conditions.
Right, surgery.
Yeah. And maybe surprisingly, Crohn's disease and its complications actually account for almost half of all cases.
Wow, half.
Almost half, yeah. Other significant causes include things like mesenteric vascular thrombosis.
Which is a blood clot.
Essentially, yeah, a blood clot in the arteries supplying the intestines, cutting off blood flow. Then there's radiation enteritis.
From cancer treatment.
Often, yes. Severe inflammation from radiation therapy. And also various tumors that mean they have to take out parts of the bowel.
That's a surprising range of causes, I agree, especially Crohn's being so prevalent.
Huh.
So once a patient develops SBS, is the body completely passive or does it try to compensate? How effective are these natural adaptations?
That's a crucial question because the body does try to adapt, absolutely. And those adaptations significantly impact the patient's future.
How so?
Well, you might think it's simply about how much small intestine is left right, just the length.
Yeah, that seems logical.
But our sources indicate it's far more nuanced than just total length.
Okay, so it's not just a matter of simple length then. What specific nuances are we talking about here? Are there particular sections of the intestine that are more critical or maybe even have unique compensatory abilities?
Precisely. While the features of SBS typically appear with less than, say, 200 centimeters of small bowel remaining,
Okay.
the length and the nature of the remaining intestine are both incredibly important.
The nature, which part?
Exactly. The diseases that lead to SBS often preferentially affect the distal small intestine, the later part. What's truly remarkable here involves two sections. The ileum, which is the very last part before the large intestine,
Right.
and the jejunum, the middle section. There's actually some evidence that the ileum, with its specialized cells and better fluid absorption, can, surprisingly, take over the functions of a missing jejunum.
Wow.
But here's the key thing. The jejunum cannot do the reverse. It can't pick up the ileum's unique roles.
That's a fascinating insight, the body's own internal pivot system, kind
Yeah.
of. What about the ileocecal valve, that junction between the small and large intestine? Was that considered particularly important? Has our understanding changed?
Yes, historically, the ileocecal valve was considered very important for absorption, almost like a gatekeeper, regulating flow.
Right.
However, our current understanding is that its perceived importance was probably more a reflection of the associated preservation of the distal ileum and the right side of the colon
Yeah.
than the valve itself having some magical property. Which brings us to another critical piece of the puzzle, the colon.
So the colon plays a protective role beyond just, waste processing.
Yeah.
How does having an intact colon actually help patients with severe small bowel loss?
It's a huge factor, a game changer, really. Patients with an intact colon are relatively protected from the worst effects of massive small bowel resection.
Protected how?
Well, because the colon has this remarkable ability to absorb not only fluid and electrolytes, which is vital, but also a modest amount of nutrient energy, mostly from unabsorbed carbohydrates fermented by bacteria. It's not a lot, but it can make a significant difference in a patient's overall nutritional status.
That's incredible. So considering all these factors, the length, the specific sections left, and whether the colon is intact, what are the real-world thresholds? Like, when does someone definitely need long-term support? How does this translate into prognosis?
It varies quite significantly, and these thresholds are really vital for clinical decision-making. For instance, patients with maybe 100 to 200 centimeters of jejunum
Okay.
surgically reconnected to an intact colon may actually be able to maintain satisfactory macronutrient, fluid, and electrolyte status.
So they might avoid IV feeding.
They might. However, even they will still be at risk for certain deficiencies, like fat-soluble vitamins, vitamin B12,
Right.
and they'll generally need oral supplements for trace elements, vitamins, and minerals.
Okay. And if they have less bowel than that?
Stepping down, some, but importantly not all. Patients with maybe 50 to 100 centimeters of small intestine and an intact colon will experience intestinal failure.
So there's borderline there.
It can be, but almost all patients with 50 centimeters or less of jejunum connected to an intact colon will undoubtedly have intestinal failure.
Okay, that's pretty clear. And what if the small intestine doesn't connect to the colon? Like, if it ends in a stoma, what's the prognosis then?
That's a much more challenging scenario. You have to contrast those previous cases sharply with patients where the small intestine ends in a stoma, meaning the remaining bowel is brought out to the skin.
Right.
In these cases, most patients with less than 200 centimeters and virtually all with less than 100 centimeters will have intestinal failure. They will require long-term parenteral nutrition.
Wow. It really highlights how every centimeter and critically every segment of the remaining digestive tract truly matters for a patient's life and their need for support.
Absolutely.
So given these immense challenges, what's the primary medical approach then? How do doctors manage patients with short bowel syndrome day to day?
Well, the medical management relies on several key components. It's really aimed at optimizing whatever absorption is possible and mitigating those difficult symptoms like diarrhea.
Okay.
So this includes antidiarrheal agents, things like loperamide and codeine phosphate, just to slow transit time down,
Makes sense.
and drugs to reduce diarrhea specifically from bile salt malabsorption like cholestyramine.
Right, because the bile salts aren't absorbed properly.
Exactly. And importantly, drugs to reduce increased gastric acid secretion, like proton pump inhibitors or PPIs.
Why is stomach acid a problem?
Because the small bowel normally helps regulate stomach acid production. It provides a sort of feedback loop, a natural break.
Oh.
When a significant portion is lost, that break is gone, leading to uncontrolled acid production, which can worsen diarrhea and malabsorption.
I see.
And of course, patients receive crucial vitamin and trace element supplements, sometimes orally, sometimes parenterally, to prevent deficiencies.
And are there drugs to help the bowel adapt?
Yes, there's ongoing interest and research into drugs that promote intestinal adaptation, things like growth hormone, glutamine, and more recently, medications that mimic a hormone called glucagon-like peptide 2 or GLP-2 agonists. These essentially encourage the remaining bowel to grow and adapt more efficiently.
So trying to boost the body's own compensation.
Precisely. But despite these advances, the mainstay of treatment for SBS, especially when it causes intestinal failure, remains home parenteral nutrition, or HPN.
This HPN sounds incredibly vital, obviously life-saving, but also, as you said, intensely demanding. Tell us more about what that actually entails for patients.
HPN is truly a life-saving therapy, no question. Its development back in the late 1960s was a monumental game changer.
Right.
It enabled the majority of patients with SBS to enjoy a reasonably good quality of life that simply wasn't possible before.
That's incredible progress.
It really is. Their long-term survival is now principally related to the underlying disease that caused the SBS in the first place.
Okay.
Not necessarily the HPN itself, assuming it's managed well. However, it's definitely not without significant demands. HPN is both expensive and incredibly demanding for patients and their families.
So demanding.
Well, it basically transforms the patient's home into a mini clinic. It requires rigorous adherence to sterile procedures to prevent infection when connecting the IV lines, constant vigilance, and frankly, a lot of mental fortitude to manage potential life-threatening complications.
What sort of complications?
Patients are at risk from significant issues. Notably, catheter-related problems are a big one. Things like infections spreading through the bloodstream, which is sepsis.
Very serious.
Extremely serious. And also blockages or occlusions of the catheter.
Yeah.
Then there are the metabolic complications from long-term IV feeding.
Like what?
Things like fibrotic liver disease, gallstones, metabolic bone disease, weakening of the bones, and kidney stones, too.
Wow, that's a profound re-engineering of daily life, isn't it?
It really is.
It highlights the immense personal cost behind this life-sustaining technology. It offers life, yes, but requires just immense commitment and vigilance from patients and their care teams.
Absolutely. It's a true double-edged sword.
Beyond this daily management with HPN and medications, are there surgical options that can help improve things for these patients, maybe beyond the initial resection that caused the problem?
Yes, there are some surgical procedures that have been developed. They're designed to try and improve the surface area for absorption or reduce the speed of transit of food through the remaining small intestine.
Trying to give it more time to absorb.
Exactly. These procedures have shown some promise, particularly in children, where the bowel seems to have more potential for growth and adaptation.
Okay.
However, their place in managing adults with established short bowel syndrome, well, it currently remains less clear. It isn't really a universally adopted approach for adults at this point.
So more established for kids. What about when HPN just isn't sustainable anymore? Maybe because of those complications you mentioned, like infections or liver problems, or the patient's quality of life becomes severely compromised. Is there a last resort? A truly transformative option?
In those really challenging situations, yes, small bowel transplantation becomes an option.
Transplanting the small intestine.
That's right. The indications for considering a transplant often include things like the loss of venous access from those long-term IV feeding complications.
Meaning nowhere left to put the IV lines.
Essentially, yes.
Yeah.
Or the development of progressive liver dysfunction that's directly caused by the HPN itself.
Right.
And what's truly fascinating here is the remarkable progress that's been made in this field.
How so?
Well, the results of small bowel transplantation have progressively improved over the past couple of decades. It used to be highly experimental with poor outcomes, but now 5-year patient survival exceeds 80% in some specialized centers.
80%, that's amazing.
It's a truly remarkable leap forward, moving it from something very risky to a procedure with significant life-changing success rates for the right patients.
That's an astonishing statistic and, yeah, profound testament to advancements in medical science and surgical technique.
Absolutely.
Wow, what a deep dive into short bowel syndrome and intestinal failure.
Yeah.
We've really gone from, defining a complex condition to understanding the body's incredible and sometimes insufficient adaptations.
Yeah.
And the truly life-changing medical and surgical interventions that are available.
And if we connect this to the bigger picture, I think the journey through understanding and treating these conditions really highlights the intricate balance of our digestive system and also the continuous innovation in medicine, which is constantly driven by the profound need to sustain and improve human life against what can seem like insurmountable physiological challenges.
So what does this all mean for you, the listener? So we wrap up this deep dive. Maybe consider this provocative thought. In an era where human longevity is constantly increasing, how might our understanding of organ adaptation and transplantation continue to evolve, not just to prolong life, but to truly transform the quality of life for those facing such profound physiological challenges?
That's a fascinating question for the future.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.